Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Welcome back to the Sit and Stay podcast, brought to you by RipsyTech. I am one of your hosts, RipsyTech product manager Parker Anderson. As always, I am joined by the illustrious founder and CEO, as I like to refer to him, Tom Tarshis. How you doing, Tom?
Good, Parker. I think we're both in good mood today.
Yeah, I think so. We ought to be in a good mood because we have a big topic to tackle today, and certainly not one that would be easy to discuss in lower spirits. So I think there's a lot to dissect in what we want to talk about today. It's something that pertains to your specialty as a provider, and then for speaking for myself, I have a lot of experience working in IOP programs with young people, so I have a little bit of experience in this, and that is we're talking about managing minor patients as a mental health provider, specifically any kind of complications that a mental health provider should be keeping in mind in terms of custody status or just, in general with seeing a minor patient. So anything you want to say before I dive into the questions?
Yeah, no, I think this is like a great topic. And like you said, it can be a little intense. And there's been a lot of learning over the years about handling custody issues, especially, parents who don't agree on treatment and things like that. And so I look forward to sharing at least what I know about this topic or have learned over the years and where things had sort of evolved with how we handle these situations.
Great. So let's dive into it. The first question I had written down was, what are the key legal requirements that a mental health professional needs to be aware of when they're working with a minor patient? And then, as we mentioned, especially in the cases of custody disputes.
Yeah, and I'm in California, and so my direct knowledge of the legal requirements tends to be California based, and there actually may be some differences in other states. However, I feel that actually most states and California with respect to these treatment principles are the same. But I'm not 100% sure about that. But let's just start with the basics about if parents are divorced. When parents are divorced, then there are two types of custody that are discussed, and it's physical custody and then legal custody. Physical custody is where is the kid living for what percent of the week. And legal custody is who has the decision-making power in the relationship. Now, in general, most of the time it is joint custody for both. There's a long history of that not being the case, but as things have evolved and people realized having both parents equally involved in kids' life is better for the kid. That's sort of changed now, so where the standard is joint custody. And say if your kid needs to get mental health treatment, well, in the state of California, in reality, you only need one of the parents with joint legal custody in order for it to be legal to bring them in for an evaluation. So if you're in California and you have a 7-year-old who's struggling in school and you want to bring them in for an evaluation, you don't actually have to ask your ex if that's okay. You could just bring them in and do an evaluation and even get treatment for your child without involving the other partner at all. And there are some entities, for example, I know from my colleagues at Kaiser, where they just one parent has to be there for the whole intake and consent process. And not involving both parents, regardless of custody status, is not a good thing. And we're going to talk about that a little bit more. But just to be clear, from a legal point of view, you only need one parent with the joint custody status to bring a kid in for a mental health evaluation. The other item worth mentioning is that in California, and this one is different in some of the states, minor teenage patients in California, it's ages 12 to 17, can actually consent to medical treatment on their own, right, without talking to a parent.
That's right.
And that even means, so if a 14-year-old wanted to engage in psychotherapy, they could go in and say, I want to do therapy, but I don't want you to tell my parents about it. And that would actually be totally legal. Now, the issue of who's going to pay for the sessions aside, or if the kid has their insurance card, whoever is the policyholder is going to see some explanations of benefits coming. But the asterisk here, which really is for prescribers, psychiatrists, is that does not apply to consenting for psychotropic medication. So although a teen could go and engage in therapy or other medical treatment on their own, they cannot consent to psychotropic medication. So any medication that treats mental health issues needs permission from a legal guardian. So those are the biggest two just legal facts that are worth starting this podcast out with.
Okay, those are really... Sorry, there's a lot to chew on there. Something that I was thinking about was, what happens when one parent is... Okay, so you said that, you only really need to have one parent there with joint legal custody. Is that correct?
That's correct.
So, yeah, I guess what happens when maybe the second parent is involved, they have joint legal custody, but then one parent wants to maybe withhold information from the other parent? What's your responsibility as a provider in that situation?
Yeah, so then we sort of jump to a couple of different categories of care. Like, one, what is best treatment practice to have good outcomes for your patients? And then there's also a sort of, how do you handle these situations to avoid, potentially a civil lawsuit from one of the parents? It may not be, criminal liability, but people can always come after you for any reason in civil lawsuits, which I think is minor to sort of what's best practice for the kid. And so, what we tend to do is, it's very black and white. So if parents are divorced, even regardless if one parent has full legal custody, we require both parents, if they're involved in the kid's life, to participate in the intake session. And, sometimes there are, of course, exceptions to everything I'm about to say. A parent could be in jail or prison. It could be a domestic violence situation. Someone could be, out of state and not known where they are. So there are these exceptions to that rule. Right. I will say, and just to share some initial stories from when I first started out, there are parents out there that don't want to involve the other parent, sometimes for good reasons, but often not for good reasons. And I remember I had one of my first cases, or when this first came on the radar, was when a parent brought a child in, and I asked about the other parent, and they said, "Oh, I'm the only one on the birth certificate. The other parent is long gone." And that's how they got into the clinic. Mm-hmm. And then, pretty quickly it came out that, it was a younger kid, maybe 6 or 7, but it came out, "Oh yeah, I'm going to see my other parent this weekend." And I was sort of like, "Wait, what?" Like, the one parent said, they were only on the birth certificate and there was no other parent. And then it quickly, that's sort of the like wake up to the world moment. Mm-hmm. And so, from then on, it's critical for best outcomes to involve both patients and care, get both parents on the same page. But before I go into more details on what we do to try to enforce that a little bit, let me pause and see if you have comments on that blog info.
Yeah, I mean, I don't have any specific comments on that, 'cause, I mean, one, it's clear from just that story alone that this is kind of like a human issue, and it's very as black and white as some of the laws are. It seems like the ways that in which you handle it. There are so many different possible variations that exist that it makes it difficult to just know off the top of your head exactly what the right answer to do, or the right thing to do in any given particular situation. So, it's making me think about like, what are like common ethical dilemmas that providers should be looking out for. Hopefully any kind of common dilemmas that can kind of help paint the picture a little bit of like, hey, when things are a little murky, at least maybe there's some kind of reference point that I can look at and say like, well, in that kind of situation you would do this, or in that kind of ethical dilemma you would do this. So maybe that helps kind of paint in between the lines, and then from the specific situation you figure out how to paint outside the lines. I hope that metaphor made sense.
Yeah, and there is another situation we'll come to discuss, which is what if you're seeing kids whose parents are in the process of getting a divorce, which is a whole other topic.
Yeah, that's one we have saved for later.
Yeah, and so what essentially it's evolved into, at our clinics, and at some point, for any child whose parents were not married or widowed, essentially, we were requiring parents to submit the actual custody paperwork.
Right.
And so they would submit the custody paperwork, and then we would require separate consents for treatment from both parents before even beginning. Now, personally, I think that went too far, and it became a barrier to care. And, in our field, we can sort of use judgment on, okay, is this a case where we should really get both parents to sign consents because we're worried about how things are going to turn out? Or, do we just make it clear that a condition for treatment in cases of divorce or separation is that really both parents need to participate, and we're not going to provide care otherwise, because if parents don't agree on care and treatment, the treatment has very little chance of success. And you can imagine this, Parker, that if there's a 10-year-old and one parent is very pro mental health treatment, wants them to be involved with going to therapy, and then it's especially complicated if medications are involved, and then the other person really doesn't believe in mental health treatment, kids don't want to disappoint either parent. And
Right.
If that other parent that doesn't agree in mental health treatment is in that kid's ear, saying whatever about the mental health treatment, it's going to sabotage the treatment. The kid's going to stay aligned with that other parent. And then, of course, you can imagine if there's medications involved, the parent who doesn't believe in mental health treatment is just not going to give them. And
Right.
then you're definitely in a situation where it could even be a more harm than good. So, in those cases, and actually as I've over the years, you sort of, I don't know if it's healthy or not, but I really like the most challenging, difficult cases possible. And some of these are around educating, informing, and talking to the parents who don't believe in mental health treatment, and seeing if we can get them to buy into the care for their kid and building a good relationship with them. But that's where the work goes to. If you see a kid that you know could benefit from help and there's only one parent on board, you start meeting with the parent that isn't on board or the parents together and see if you can reach a state where they see the potential benefit. And sometimes it works and sometimes it doesn't. I don't know if I can quote the success rate there.
Well, I'm curious, like, what's the approach? Like, what's the strategy when initiating that conversation?
Yeah, it's as a therapist and clinician, it's a sit down, be a good listener, and figure out where's the resistance or desire not to have mental health treatment for the kid coming from. I would say more often than not, it's because of a direct experience when that parent was maybe a kid and they felt like, quote, some treatment was forced on them, or, they had were prescribed a medication that they didn't agree with and made them feel bad. And in those parents' defenses, it is something I can always empathize with, that there are a lot of parents who experience bad mental health care growing up, and especially parents who grew up 70s, 80s, 90s, where we've advanced a lot more today than back then. So empathizing with that, and that sounds awful, and here we always talk with kids, no matter what their age, about what the treatment you're going to do, or if you took a pill, right? And that it's a very different approach to feeling like something's forced on them. The other reason is, they've seen someone or another, they've seen it's usually some sort of other experience with psychiatric treatment causing a lot of problems. I think it's less these days about the kid being labeled with any type of psychiatric diagnosis or going into a clinic, but that's probably still present as well. So can you be a good listener, understand those reasons, educate on what's happening, talk about, hey, there's no secrets here, everything's consented, we're going to answer questions. That's how you can turn some people around coming into to bring their kid into treatment.
Okay. So I imagine this is something that kind of pertains to all types of different providers who any kind of healthcare provider who sees children. I'm wondering, like, what does a provider do when the best interests of the child maybe conflicts with what the parents want to do for their treatment? How do you balance? How do you approach that situation where maybe one thing is the best thing for the child, but the parents are, in conflict with that best interest?
Yeah, right. Here one parent's always signed the kid up for the appointment. So you usually always have one parent in agreement with treatment. And, in our clinics, we always offer therapy and, medication treatment. So we make it clear that we're not chugging out writing prescriptions all day and let's talk about, here's 3 different realms of treatment and things we can offer. The reality is, in other fields in medicine, for example, a kid has appendicitis. One parent says, no, I, for religious or other reasons, may not believe in medical treatment. It's a little more clear to sort of, we're going to disregard one or both parents' wishes and save this kid's life. Like, unfortunately, that is not really, even though mental health treatment does save lots of kids' life, you're not in that sort of urgent black or white, this kid needs to be seeing a therapist or a psychiatrist or something awful is going to happen. And so your hands are tied a lot as a clinician if you have a parent with joint legal custody that's adamant about not wanting the treatment. And there definitely are times when when I've been very worried about kids with more severe diagnoses, that you might be having a conversation with one parent to, hey, you need to go to court and get full legal custody and decision making. And at least here in California, almost always the judges will side with the parent trying to get mental health treatment for their kid.
Right.
And it's extreme to do that, but we have done that.
So, I mean, are there ever times where maybe a parent comes to you saying, hey, I think we need medication for my child, and you say, actually, that's not the right way to go?
Yeah, all the time. And the good news is most people come and say they want an evaluation, and if someone's just, maybe someone had another experience or has been seeing a therapist, and the therapist recommended a psychiatric evaluation or something like that, and that's totally reasonable. But yeah, we, within our clinics, if medication is not appropriate, we definitely will not be prescribing medication. But we'll do an evaluation on anyone and talk to parents about what we think are the right treatments.
Well, I'm happy to hear that. Okay, so I want to touch on something that you kind of briefly previewed that we'd be talking about earlier, which is what happens when you're seeing a patient, a child patient, and the custody arrangements maybe change during the course of treatment. Perhaps there's a few different examples of this. I think maybe the majority. The majority would be if the parents are getting a divorce in the midst of treatment. How do you navigate that?
Yeah, that one's an easier one, because if you've got the family engaged in treatment and the kid's been coming and you've met both parents, that tends to be much easier than the case of a new patient coming in while the parents are in the midst of the divorce. And it's you can see that it's going to be a battle. But to go back to the former, hopefully you've developed a good relationship with the parents. It is indisputable that it's not actually divorce that's so terrible for the kids. It is how the parents treat each other when they're with the children and when they're not with the children, with respect to not saying bad things about the other parent. And it's all about how well you co-parent that determines whether or not the divorce is going to take a mental health toll on your children. In general, the younger the kids are at divorce, the better the outcomes, just in general. There's data to suggest that actually the hardest age for your parents to go through a divorce is when you're in college, so you're not even legally a minor anymore. But college students whose parents divorce tend to have the worst mental health outcomes. It's not definitive, but there's definitely the older kids are when the parents divorce, the worse the outcomes are mental health wise for those kids.
Any speculations on why that might be?
Yeah, I think divorce is an emotional process, and if the kids are very young when it happens, even if there's several years of conflict or problems, with time the emotions die down. The parents meet someone else, and the level of conflict kind of balances out before the kids are even old enough to have strong memories there. So I think that's why it's very subjective. There's lots of different theories about this. In addition, very young kids aren't as aware of what is a relationship, or having romantic feelings towards someone else. And once the kids get to 9, 10, or teenage years, they know about relationships. It's very distressing to them that their parents don't love each other anymore. And then there's other concerns as well about where are we going to live, what's going to happen financially. And then if you have parents, unfortunately, a lot of sharing of adult information tends to go on with kids once they hit 10, 11, 12, 13. And, it's apparent you can empathize with parents who do that because they're looking for someone to understand their suffering, but it has very poor outcomes when you're using your kid as a therapist or source of support while you're going through a breakup.
Oh, that's so interesting because I feel like most of the depictions of it in the media are, like, oh, we waited until they were 18, like we stuck it out for the kids, and the research might support the opposite. That's really interesting.
Yeah, so always, and Parker, as someone who's about to embark on this marriage journey, our advice is always, the best thing you can do for your kids is take care of your relationship, like without a doubt. Now so theoretically, quote, people sticking it out till the kids are 18, if they've stuck it out with perfect co-parenting and a happy household and then, I think that's a different case scenario. But if you're in your mindset sticking it out till your kid's 18, it's hard to hide that perfectly. And kids and teens are perceptive and bright and they know there's problems. So sticking out a unhappy relationship till the kids reach some magic age in general is not good for the kids nor for you. Like if the relationship has ended, recognize it, get help with co-parenting and splitting up, but like move on. The only thing that's going to make it better is ending it, getting new life and routine established and letting time pass.
Well said. Very, very wise. That's good stuff. Okay, so last thing I want to ask you about is best practices, specifically when you're documenting different treatment decisions and interactions with parents, with cases that do involve custody disputes.
Yeah, so and this is really where you're going to use your intuition as a clinician and be careful because, well, as you know, Parker, in some highly contentious divorces, there are forensic experts, social workers, therapists, psychologists, and psychiatrists that are hired sometimes by the courts to evaluate the kids and where they should live, and other times privately can be hired by one of the parents to do an evaluation and to go on the stand and say why the kids should live with them. So if there's a custody dispute, there are likely going to be mental health professionals involved in the court hearing that's going to happen. Oh, wow. So what you need to be very acutely aware of is that if you take a new patient that is in the midst of a divorce, and this is absolutely something that I recommend everyone do, there's a separate consent form that says you're coming to our clinic for treatment only. We will not be performing any type of forensic evaluation, nor will we ever release any treatment records to any court under any reason. Now, records can always be subpoenaed and you never know what can happen, but you can really fight to keep those private. And we get both parents to sign that to make sure that they know that we are not there to be the forensic expert to say who the kid should live with. That we're there to do what we think is best for the kid and to provide that treatment. Regardless of that, parents will try to do things like so along with that, part of that is there will never be phone calls that are not conference calls. There will never be emails that don't go to all parties involved. And there will never be any if there ever is, if you even send an email that your partner or soon to be ex-partner is not copied on, we will forward it and say with the reply to make sure everything is completely transparent. because you don't want to get in the habit of answering a private email to one of the other parents. Because it will create problems with thinking, oh, that clinician is taking the other parent's side, or why are they talking privately?
Right.
And
makes sense.
And we can give, names of people who will do forensic evaluations. And I haven't done any forensic evaluations for custody. It is intense. You're going to have, children are the most loved thing in people's life, and you're going to go up there and say the children should live with parent X, and one parent is not going to be happy with you.
Right.
And because of that, you charge extra money. You don't take insurance, and that money is well deserved. You're putting yourself in a stressful situation, and kudos to those people who do those evaluations and are willing to navigate that for the sake of the kids. But so all communication among all parties, have both parents sign, this is not ever going to be used for forensic reasons. And then do your best to try to bring, if they're fighting over custody, they are not co-parenting well. So can you,
Right.
The real accomplishment and the best thing we can do for kids is somehow bring those parents together for the sake of the kid, on routines, on not bad mouthing the other parent when they're not around. And it's nice when you have success there and actually even get people to drop those lawsuits is nice.
Are there any kind of extreme situations where a parent might give up their right as a parent? And I'm just trying to think of if a child is really struggling, maybe needs a higher level of treatment, and the parent is maybe not, it feels kind of intense or harsh to say, but not willing to accept responsibility, or has just kind of become too wrapped up in the whole thing. And and I guess, have you ever kind of been in that kind of an intense situation where a parent might kind of give up their rights as a parent? Does that make sense?
Yeah, I mean, there is a terminate parental rights. It's often not something initiated by a parent, but for abuse or other reasons, the court system will intervene and terminate parental rights temporarily or permanently. And we've had did some evaluations for minor youth from other countries that were in the U.S. without a parent or guardian and wanted to stay, and have done some intense stuff around that. The courts really tend to do what's best for the kids and really listen to mental health providers. If you're coming in a case where there aren't parental rights or it's a foster youth, you have a lot of power to make a positive difference for kids. I think the stereotypical parents fighting over legal custody status and spending hundreds of thousands of dollars, trying to prove that they're a better parent. I think, the court system and judges don't treat that the same way as
Right.
the youth that are in more desperate need. Yeah.
Well, before we move on, anything else that you'd like to say covering the topic?
No, I think I mentioned that, one of the old clinics I was at started requiring the custody paperwork regardless of if the parents had a good relationship. And I
Right.
really don't think that's the funny thing that happens there is, often parents don't really have it, or they haven't done it, or, they've lost it. Or I really don't think that's necessary unless your radar is going off that you think something is very suspicious. you do get cases where people on the registration form will put the name of their new partner as one of the parents, and it's like, wait, this isn't, so it needs to be, you know, biologic, not necessarily biological, but legal, full legal guardians. And in those cases where your radar does go off, then you're totally within your right to request a copy of the custody agreement. But I think, hopefully in your skills as a therapist, you're savvy enough when to know to ask for it, and automatically asking for it on every case it just becomes a barrier to care.
I know we're going a little past, a little over the time that we wanted to, but I feel like I still have more questions.
Sure.
Have you ever encountered like an emancipated minor, a minor who has taken full custody of themselves, I suppose is how you'd phrase that. And in that case, do they have consent to, do they have the legal power to consent to psychiatric medication?
Oh yeah, good question. And definitely over the years, I've probably just a handful of usually 16 or 17-year-olds that are working, like both their parents are, not around or incapacitated to some level, and they taking the initiative to get emancipated, and then they're usually taking the initiative to make the appointment for themselves. So that is a real thing, and we've seen it over the years, and it's usually, it takes some time. So it's not like I've never seen emancipated 14-year-old, but definitely We've seen likely one 16 and several 17-year-olds that have done that, so that they could take care of their own lives, essentially, which they've usually been doing since a young age anyway. And they'll have that paperwork. And
Gotcha. So, I guess in that case, like, because a minor who's still under, still like legally considered a minor, and their parents have legal rights over them. Yeah, you mentioned that they can still consent to their own therapy, but not necessarily medication. But in the case of emancipated minor, is that something that they do have the right to?
Yeah, they do. They do have the right to consent to any and all medical treatment
okay.
if you get the emancipation.
Gotcha. Okay. Well, that seems like a good part to end on. How about we move on to the mental health business moment of the week? What do we have?
Yeah, it's a good question. I usually try to think about this before the podcast, and I'm realizing I haven't thought about it before the podcast. So let's just see what, if anything pops into my mind. Yeah, well, let's see. Well, I mean, I can mention that, like, in our nonprofit, we've just sort of passed the quote 1 year mark of being reactive. So we're going to insurance companies and asking for an increase because we weren't able to get yearly increases built in. And so often in years past when I've done this, you get a sort of immediate no note. But I will say that one insurance company that is known for sending back the no said, thanks for the information you've provided, and we'll review it and get back to you within 60 days.
That's not a no.
Which is, yeah, I was like, we always put together a letter and like, here's how many of your patients we've served. Here's how many visits. Right. Here's how many have requested appointments. Here's how much you're underpaying us. So it's a little bit, it was a little bit interesting because I actually don't know if that's ever been the response from this particular insurance company that will get back to you within 60 days. I don't even know if I should feel, I certainly more hopeful than the immediate no, but I don't know how hopeful to feel about it. And it is this, we haven't officially done it yet, but we're going to not accept any more patients with this insurance because it literally pays 50% of some of our other insurances, and we have to watch the payer mix for running the clinic. But
right.
That is really easier said than done, because I do, when our phone call rings, if I'm not with a patient, I tend to answer it. And this is something I know about myself. Like, if you've got a parent desperate for help for their kid, I just don't ask what their insurance is on the phone.
Right.
Like, if we have an opening, we have an opening, fill out a request form. And in my mind, I'm thinking, please don't have X insurance. But I just took one of these calls yesterday, and unfortunately it was insurance X, but I'm going to help the family because,
that's what you do.
That's what you do. And I feel like insurance companies and people take, anyone who's become a clinician or mental health professional, you do it to help people, and it is just not possible and probably shouldn't be to say, sorry, I'm not going to help you because your insurance doesn't pay well.
Right.
But yeah.
Well, just a quick follow-up question before we end. Is that something that you recommend people doing if they have a contract that doesn't guarantee a yearly increase, that they reach out to the insurances that they're contracted with to ask for something like that?
100%. Yeah. And you should keep a spreadsheet and log and who are the point people and track visits and put your letter together, and whether or not they respond or give you an increase. And we have a strategy where if they deny it, then 6 months after that, we might push again. But once a year at a minimum, if you don't have those built-in increases, you go after them. Every single year, insurance companies raise their rates.
Right.
And in general, you can even look up, like in California, Anthem increases rates 8%. It's usually 8. It's a high amount if you know the GDP of the healthcare industry insurers. And yeah, so you can say, hey, you increased your insurance rates 8%. We'd like our 8% increase as well. Or, you usually don't specify 8 or nothing. But then if they do come back with, it's hard for them not to give a percent increase when they're increasing their revenue. And
right.
Good question, Parker.
Thank you. All right. Well, there you have it. Another good episode in the books. Thanks for joining us for this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. If you have questions, please submit them to our audience Q&A at sitandstay@ripsytech.com. That's something that we should do that. We should do that soon. Hope maybe sometime before the end of the year we can do an audience Q&A episode. And as always, if you're interested in being a guest on the show, we love having guests. Send us an email at sitandstay@ripsytech.com. Start a conversation. We'll, get to know you, and if it's the right fit, we'll go for it. All right, Tom, I'll see you later.
Thanks, Parker. Have a good one.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.